first in a two-part series on infection prevention sustainability. This particular session is focused on the clinical setting, and our speaker, Jean Lyon, is going to cover that very well for you. Jean is a clinical care practitioner and a senior infection prevention advisor for Comagine Health. She's a family nurse practitioner and a psychiatric mental health nurse practitioner. She has a master's degree in community health nursing and a doctorate in nursing with a focus on administration. She has experience in multiple healthcare settings, and prior to her tenure with Comagine Health, she worked as a surveyor for the Joint Commission on Accreditation of Healthcare Organizations, surveying a variety of outpatient and inpatient ambulatory care settings and critical access hospitals. Jean is the lead clinical and curriculum specialist on multiple state infection prevention projects, including the National Nursing Home ECHO project. Jean, could you just say hi to everyone so we can do a sound check?
Yes, hello everyone. And I see a number of names here of people who I know, either from other programs or Martha Jaworski. Nice to see you're on the call too, Martha. So I hope everybody can hear me just fine.
If you can, please just type yes into the chat so that we know that. Excellent. All right, Jean, I'm going to turn it over to you.
Oh, thank you, Donna. Okay, we have a big agenda here today and just an hour to do this presentation. So we will not have time at the end for questions and answers, but there will be an incredible amount of information that is presented today. You will have access to the slide deck. We're also going to be doing this with a voiceover, so it can be used for educational purposes in the future by you and your facilities. And you can use all or part, whatever you choose, however you choose to use it. The other thing that's going to be available is a facilitator's handbook, which will have much more in-depth information from a surveyor's perspective on what you always hope to see when you go into a facility that you're surveying. So let's go to the next slide. Okay, so this presentation today, we have 6 objectives. We're going to discuss the infection prevention F-tags, including the new F-tags, and understand the importance of being in compliance with the regulations. We're going to talk about how to develop a complete infection prevention control program, including an antimicrobial stewardship program. We'll discuss that in great detail. Identify through observation a minimum of 8 circumstances that could be cited for noncompliance with infection prevention and control practices in clinical areas. Conduct environmental rounds using knowledge that you gain to correct observed deficiencies in your own buildings. Identify the most common infection control citations, both prior to COVID and during the pandemic, and use the content of the webinar to train your staff on circumstances that could be cited for noncompliance in infection prevention and control practices in clinical areas. Next slide. Okay, so we're going to have this set up in the facilitator's guide with pre-test questions, and then we'll have post-test questions afterwards. So you can really use this as an educational curriculum and even offer continuing education credit for the hour if you choose to do so. Next slide. Okay, so here are the F-tags. We have F880, which is infection prevention and control, F881, antibiotic stewardship, 882, infection preventionist qualifications and role, 883, influenza and pneumococcal immunizations, 884, reporting to the National Health and Safety Network, F885, COVID-19 reporting, and F886, COVID-19 testing for residents and staff. So there are a total of 7 F-tags pertaining to infection prevention and control. Each one has the potential to be out of compliance and could be cited during a survey. We'll discuss each one briefly, but F880, F881, and F882 we will discuss in detail, as these comprise the foundation of a solid infection prevention and control program. Next slide. Okay, so F880 is the foundation, as I said, of your infection prevention and control program. It needs to be a written document that is detailed and very comprehensive. One tip I can give you as a former surveyor is if you can appear to be very organized when the surveyor comes in the door, if you can have your whole infection prevention and control program in one location, like a binder, where you have the program written out, you have a tab for who the members are, you have a tab that has your risk assessment in it, your surveillance, what you're looking at, your data, what that's being reported back to the infection prevention committee, and then on to the quality improvement committee. If you can have the minutes all in one place so that all you have to do is hand that over to the surveyor, you are going to wow them. Let's go to the next slide. They're going to know you're organized. Okay, so an antibiotic stewardship program, that's F881. It needs to be part of your infection prevention and control program. We will discuss this standard in detail today. F882 refers to the infection preventionist qualifications and role, and we'll also discuss that in more detail today. F883 requires the facility to offer influenza and pneumococcal vaccinations to residents. There needs to be a process in place where the vaccines are offered, and in the case of the influenza vaccine, the month when the vaccinations will begin. Your policies and procedures need to be in place that will describe the process. Documentation of the vaccinations that were given, as well as the risks and potential side effects, must also be documented. All of this, the policies and procedures need to reflect what you're doing. You need to document what you're doing. And if it's not documented, more than likely you'll be at risk, definitely at risk for a citation. Next slide. Okay, the F884 requires every nursing home to report data to the National Health Safety Network, NHSN. You should all be very familiar with this network by this time. Each nursing home should have at least 2 staff members who have access to the system for data entry, and you want that SAM code 3, I think it is, the highest level, so that you can handle, you've been approved to have access to PHI, personal health information. If you limit the number of people to just 1 and not 2 or more, then you run the risk of having a deficiency if that individual leaves or if they get sick, if they move away, because it is time intensive to get that clearance. So make sure you have yourself protected, because if you don't enter the data on a weekly basis, you will be fined. Next slide. So F885 is the COVID-19 reporting of residents, representatives, and families. And COVID vaccinations of residents and staff are required to be entered into NHSN weekly to avoid penalties. Again, you have to have a policy and procedure that outlines the process that is followed to report COVID-19 outbreaks in the nursing homes. Documentation of the contact of having had contact with residents, their representatives, and families is essential to avoid a citation. Let's go to the next slide. You must also know when testing is to be conducted in your facility. There are more asymptomatic cases of COVID being reported now in vaccinated residents and staff members. County positivity rates in the local health jurisdictions determine the testing frequency, and you must continue to do the testing on whatever frequency you're assigned to based on your community positivity rate. And it is not required that facilities test visitors, but CMS notes that facilities may test to facilitate visitation. However, resident and staff testing should be prioritized, and facilities should ensure that they have adequate testing supplies to meet requirements before they consider testing visitors. Next slide. FTAG resources. Obtain a copy of the CMS has the State Operations Manual, Appendix PP, and there are This document was last updated in 2017, and there we know that there are 3 FTAGs that have come about since then, F884, F885, and F886, that are not in the State Operations Manual Appendix PP at this time, but they can be scored if your facility is not in compliance. So go online. We have the last 2 slides. 2 of the last slides in this presentation have all of the links to all of the resources that we're talking about today. So you don't need to bother to copy them down. They will be accessible to you. But the State Operations Manual is about 750 pages right now, and it covers everything that you need to know with examples. So it does benefit you to print that out and start reading it. And then the infection prevention FTAGs come around page 630 in that area. So you have to know not only what's in that resource, but also you have to know these other 3 FTAGs. Next slide. Okay, so now we're going to talk about these 3 FTAGs in depth, because F880 is the foundation of the infection prevention activities in your nursing facility. So you must establish a comprehensive infection prevention and control program that's written and maintained on a regular basis, reviewed by your infection prevention committee at least annually. And the goal is to provide a safe, sanitary, and comfortable environment in the facility. The purpose of the program is to prevent the development and transmission of communicable diseases and infections. Next slide. Okay, so your program, and you'll want to take note of this, you need to have, at a minimum, an assessment of your environmental risks, policies written in accordance to 483.80A2 that follows accepted national standards. There should be as many policies and procedures as you need to manage your environment. A system for recording incidents identified under the IPCP and corrective actions that were taken by the facility. That should also be in that infection prevention binder somewhere to show that you really are working on your program. And examples include how to store, process, transport linens to prevent the spread of infection, because that is one of the highest FTAGs that get scored. Okay, next slide. And each year you need to review your program. Reviewing the program provides direction for the focus of your program for the following year. You want to, one thing I like to recommend is that the infection preventionists, organize a group of interdisciplinary representatives who on a regular basis make environmental rounds. So having people such as maintenance, environmental services, nursing, dietary, and of course, senior leadership to identify where the issues are and correct things in real time, rather than waiting until the surveyor comes in and sees something and gives you a tag on it. And then make sure you have that antibiotic stewardship program in place, because that also is a component. And we'll talk about that in a moment. Next slide. Okay, your policies. These are just some examples of policies and procedures, but you probably will need many more infection prevention policies depending on your environment, your facility. But things such as how to handle, store, process, and transport linens, like I said before, because that can spread infection, and that also is commonly scored during survey. Your standard precautions, types of isolation, the duration, when it can be discontinued, and you always want to make sure you identify the least amount of time and the least restrictive isolation that is needed based on what the organism is. Hand hygiene. Everybody does the ho-hum. We know all about hand hygiene. We hear about it all the time, and it's not very exciting. However, it is the #1 tag that people get scored in infection prevention. Food handling, safe food handling, and surveillance. Your plan and your process and your data results and what your committee has decided to do based on those results. That all should be in your plan. Next slide. Okay, so pre-COVID, these were the tags. And what did I say? Hand hygiene, poor hand hygiene. And these are usually scored because the surveyor observes a staff member not performing hand hygiene, or maybe gelling in when they go into a room, but not gelling out on the way out. And you have to gel in and gel out. Improper handling of linen, somebody carrying dirty linen, holding it against their uniform, walking it down the hall. That also is a common tag. Improper cleaning of equipment, such as glucometers. Now, this one really makes me gag a little bit. If you have a number of diabetics, you really should have a glucometer for each individual that is labeled as their own glucometer, because there have been several tags where glucometers were not cleaned between patients. And if cleaned maybe with alcohol, which was not the recommended cleaning procedure, but from the manufacturer. So you can often get glucometers for free for diabetics. So I would highly recommend that that would be the better practice, the best practice. And then also lack of proper infection prevention measures, lack of development of an infection prevention and control program, which you think, that's F880. That's number one. How could you not have a developed infection prevention and control program? Well, maybe your corporate office sent you one, but it hasn't been modified to suit the needs of your particular facility. Or maybe somebody started to write one, but it's not in depth enough. So be aware that that is a common tag. Next slide. Oh, and what a surprise. We see post pre-COVID, so during COVID-19 and the pandemic of 2020, we still see hand hygiene coming up as a problem. Lack of hand hygiene and hand washing. So the other problem that we all know that nursing homes suffered from was not having enough personal protective equipment going into the pandemic. But in addition to that, staff often do not use the PPE correctly. Maybe they don't know when to wear a gown. Maybe they don't know. There have been examples of people leaving a room, taking their mask off, putting the mask on a dirty table, all kinds of things. So you really need to watch this. And if you could get people who just are your secret shoppers to keep an eye out, and then let people know when they're making mistakes or just not thinking. Maybe they're rushed and not paying attention to what they're doing. Improper sanitation of equipment. Another thing that I used to score all the time was clean equipment stored with dirty equipment. The ideal would be to have a clean room for clean equipment, a dirty room for dirty equipment. If you don't have that, then you need to try to somehow separate the room, divide it somehow so you have clearly identified the clean side and the dirty side, and don't put dirty items on the clean side. That will get you a score, I promise you, a tag. Staff allowed to work when COVID positive, believe it or not. There was one example of an assistant director of nursing who worked for 5 days when she and other people in the facility knew she was COVID positive. So you want to make sure that does not happen. And staff and residents were not wearing masks. If you have residents who have dementia and they just will not keep a mask on, that's acceptable. However, you must have a physician or provider identify that that is a problem, have that documented in the health record, the medical record, and also very clearly say that you have tried to get the individual to wear a mask and they will not. If you don't do that, then a surveyor can say, hey, you're just not making residents wear masks. So you have to have that documented and stipulated by the provider that that is a necessity. The documentation is a necessity that the person will not wear a mask. There really is no excuse for a surveyor ever finding a staff member not wearing a mask. So that's just an obvious mistake. Residents were found to be eating together during the time when this was not allowed, when they were supposed to be in their own rooms. So that all scored during the pandemic. Next slide. Okay, environmental assessment. So what we're going to do now is look at a few examples and see if you can identify the opportunities for improvement in each of these photos. Take a few minutes, or probably a couple minutes, and look at each photo and identify with your surveyor eyes what the problem is and why it would score. And then what we would like you to do is put your answer into chat. Next slide. Okay, so this is a wall in a bathroom. So let's have you identify what the problem is here.
So far, we don't have any responses.
There we go.
Here we go. One says paint chipping, wall texture.
Correct. What's the problem with the, looks like the wall's pretty banged up. What's the problem with that? Why do you worry about that?
Dirt buildup along the co-base.
Yep. Yeah, Carolyn, excellent, excellent. Yes, yes, yes.
There we got not cleanable surface, can't be clean, dirt buildup, not cleanable surface, it's dirty.
Yeah, you're all correct. And paint, wall chipping provides space for buildup. Yep. You cannot really terminally clean that wall, can you? And it's in a bathroom. So really makes it impossible to do. So that would be an F tag. So correct. Anybody else? Okay, we'll go on to the next slide. That's fine. Okay, this is a bathroom sink. What's the problem here? I know they're typing, Donna. We have to just be patient, give them time to get those
we do,
fingers moving.
There we go. Dirty dishes in a clean area.
Dirty dishes.
Dishes in the restroom, dishes in the sink, no liner in the trash can.
Oh, I like that one. That's correct. No liner in a trash can.
Yep, used for dishes and hand washing. Trash in the sink, no liner in the trash can. Clean dishes are not in a dirty sink. Dishes should not be in the bathroom.
Excellent. What about the volume of paper in the trash can?
Oops, someone also pointed out that there's paint chip above the sink again.
Oh my gosh, you're right. Angela, great. I actually had not noticed that myself. Excellent.
Yep, Belinda and Angela both got that electric outlet by the sink.
Yeah, you'd have to look, there are construction code standards that you really need to know about when you're doing construction, and infection preventionists are always expected to be involved in any kind of construction or remodeling project. And there are specific standards of how high up off the ground your soap dispenser or hand hygiene dispenser can be, how many inches off the ground your paper towel dispenser is supposed to be. The faucets look spoiled. Well, obviously nobody's cleaning this bathroom, right?
Yeah. Someone else pointed out there's garbage on the floor, which if you look really close, there is a paper towel there.
Right underneath the sink.
We've got some good eyes here going for surveyors.
Oh my goodness, I'll say I'm impressed. If all residents are fully vaccinated, I thought they didn't need to wear masks. Actually, that is not the case, because there are a couple of reasons for that. I don't know of any facility, and excuse me, correct me if I'm wrong, but I have yet to hear one facility that has 100% residents vaccination, fully vaccinated, and 100% of staff vaccinated. So so as a result, that standard does not apply to nursing homes. You must continue to wear your masks. You must continue to do testing at whatever frequency the health department requires based on your positivity rate in your community. Now, it is true, if you go out outside, or if you go into the grocery store and you're not really coming into close contact with anyone, you don't have to wear a mask, but that is not true in skilled facilities.
Yeah. And there are different states have different regulations regarding
True.
that. I do know, for example, in Washington, that if it's all vaccinated residents and no one else, then yes, they can take off their masks and they don't have to social distance. But if one unvaccinated person comes into the room, then they all have to put a mask on. So you have to be aware of that.
Yeah, and what is happening right now with the Delta virus, the Delta variant, is it's getting into nursing homes, and fully vaccinated residents and fully vaccinated staff are testing positive to the Delta virus, testing positive to COVID. And then when they actually do the additional testing, they're finding it's Delta virus that is being brought in by non-vaccinated staff and non-vaccinated visitors. And we know that non-vaccinated visitors, you can't ask them if they're vaccinated. They can offer that information, but if somebody doesn't want to be vaccinated, they're not going to tell you they're not vaccinated. So those people must wear masks. So check with your local health department or with your state. I know I reside in Nevada, and in Nevada, you have to wear masks. Let's see. So, Catherine, let me ask you this. She stays in her room for meals, etc. Yeah. I don't know what state you're in, Catherine, but I would check with your state health department, because that one resident not vaccinated could be a tag for you if everybody else decides not to wear a mask. So you want to be very careful about that and not make assumptions when you find out that that is not does not apply to you. Okay, so let's go to the next slide. You guys are doing great. Okay, so clinical office. What's the problem here?
Boxes on the floor, stuff stacked on the floor, boxes directly on the floor.
Donna, I will be
Trip
back.
hazard.
I have to rescue my little dog. I'll be right back.
Okay. Yes, I love that the HIPAA thing, because if those are actually records, confidential information, sensitive, personal, private healthcare information, then yes, absolutely HIPAA. Trip hazard around the corner. Yes. So that is absolutely what this is, that it is a fire hazard. The boxes should not be on the floor. And if it is confidential, private healthcare information, then it should be locked up and not just in boxes on the floor. I wanted to check here. We have someone who's raised their hand. Is that because you have a question or you need some assistance with something?
Okay, sorry about that. All right. So what did we come up with here?
Quite a few boxes on the floor, stuff stacked on the floor, a trip hazard around the corner. One person even pointed out it could be a HIPAA violation, depending on what's in the boxes.
Absolutely. Excellent. Also, the boxes, it's probably too much from a fire code perspective, too much paper in one area. You have to make sure the space is sprinkled and it's all on the floor. You want to get that stuff up off the floor. Okay, next slide. Okay, laundry room floor in front of the washing machine. People should have a good time with this one.
We don't have anything yet. Oh, here we go. Missing floor tiles, uncleanable surface area.
I think we may have future surveyors among us.
Ooh, leakage, unable to be cleaned, mildew potential, not cleanable surface. Looks like the washer is leaking.
Yeah, it does.
Slips, falls.
Yeah, so it's a safety problem as well.
It's a whole nother tag.
Yeah, I know. I know. And, say you're doing walking rounds with your group, with your team, and you see this. What are you going to do? You don't want that there when a surveyor comes in, right? So that's why it's important for senior leadership to be involved in those rounds, because say the administrator or director of nursing or COO sees that, they need to budget to get that fixed. They need to find money in the budget to fix that, because it will be a tag. And it does look moldy and it does look dirty. And I think it's just gross. So the floor is unfinished, the tile's not extending under the machines, which makes the floor unable to be properly cleaned.
And the washer absolutely is leaking, which is why they have something in front of it.
Right, a towel to absorb the leak. Yeah. Plus, you can see up above, just up above the towel, it looks like you can see where the water's been dripping down. So you may need to whole new equipment. So you may need to invest in some capital budget money to do that. Next slide.
Well, this is always a good one to see in the buildings, isn't it?
Yeah, it's like, oh boy, it's like the person who uses the last of the toilet paper. Like, who did that? And now there's no gloves for me. And what am I going to do now?
Yep.
Yep,
So
it's
we
empty.
have no gloves and it's empty. Out of gloves. But Jean, you pointed something out while we were building this presentation about this whole thing. So I think that's an important tidbit to share with them.
The question, first of all, is where are the gloves? And when gloves are put in the box, what size will they be? One size glove does not fit all. And I have another picture that I took that is a good one, that is a stack of glove holders, 3 in a row, and the middle one, which was medium, is empty. That box is empty. And then on the top, they stuck another box, which is extra large, because somebody there wears extra large gloves. And yet the one that's used most, which is the medium, wasn't there. So on the non-clinical presentation, I'm going to insert that photo, because that really is. And then the gloves in the extra large are kind of falling all over the place. So it's really a good demonstration of what not to do. So what else had I said, Donna?
That was the big one about having the just even having the place for 3 different size gloves and still having to stick another box on top and things still being
yes.
empty. Yes.
Yeah. Yeah.
So, that's another good point while you're doing your rounds, to look to see, are there things like this? And then what's the process for making sure that they get filled? That should be part of what you're looking at in your infection prevention and control program. Isolation carts, anything that has PPE equipment in it, there should be a process for making sure that it's filled up.
Same thing with sharps containers that are overfilled. Who's responsible for closing those up and changing them out with an empty one? Because that's a real hazard for somebody sticking themselves. And then you never know where that needle was. If it was a sterile needle that never got used, or if it was used to draw blood, or give an injection, or what it was used for. You just don't know. Let's go to the next slide. This one may be a little trickier, but we'll see if people get this.
While you're in the hallway, equipment impeding walkway. Everything is not on the same side of the hall.
That's all correct. The handrail is blocked. Yeah. So if somebody is trying to walk, they can't walk on that side of the hall. The thing with equipment is equipment that is not currently in use does not belong in the hallway. So this Hoyer lift might have been used at some time during the day, but it's not currently being used, so it needs to be in storage, cleaned and stored. So clean it, put it in the clean storage room or part of the room that's clean. The other thing is the medication carts down at the end of the hall. We're assuming they're locked, but they're unoccupied. So they also don't belong in the hallway unless they're currently being used for medication administration. The key with this, with equipment in the hall that's not being used, is it makes, in the event of a fire, it makes evacuation difficult. In the event you have to evacuate, usually we defend in place in healthcare and don't evacuate people. But if you did have to, this would be a problem.
Yeah.
So
Someone else,
especially at night when, the lights are out and you can't see anything, people are knocking into the stuff. Yes.
someone added in here that it looks as if the janitorial cleaning is next to the med cart.
Yeah. What's the problem with that?
I think these guys really do have surveyor eyes.
I did know they have surveyor eyes. And the other problem that you see that gets scored is when you have an unaccompanied mop bucket that has water in it. You can't have that. You have to have, in fact, what most places are doing now is just using the micro fibers mop things. You use one and then put it in the dirty laundry. Because there have been cases of demented patients actually drinking the water out of those mop pails. Eek. So if you do have water in a mop pail like that, you need to have it secured like a top on it and it's locked. And so any janitorial cart that's left unattended is another great opportunity for a surveyor to say, this is beneath the standard of care and we're going to tag you on this. The problem with older buildings, of course, is they tend not to have enough storage areas for equipment because when they were built, people weren't thinking, or either that or they had the rooms for storage, but then over time, people have taken those rooms for offices, which has created additional problems, right? So, okay, so you guys got that one right. Let's go to the next slide. And if you can't identify what that is, that's a doorstop. And if you can't identify it, that's a good thing. That is a good thing.
We did have someone put in doorstop.
Okay. Okay, trip hazard with
Unclean.
doorstop.
Yep.
Floor looks dirty. Yeah, the floor is dirty. What's the problem with doorstops? Why should you not have any doorstops anywhere in your facility?
Yeah, someone's saying not allowed fire hazard against fire code.
Yep.
The door is a fire door hazard.
Yep, you cannot prop doors open.
Yep.
Correct.
We just had somebody put that in there. Yep. Life
Yep.
safety violation.
Oh, you guys, you must be surveyors or you do your mock surveys. Whoever, these people who are getting all of these answers right, contact them and have them come do your mock survey. Teach you how to do that and make those environmental rounds because you're really catching these. So that's good. All right. One more.
Stains on the ceiling tiles, water leak, leaking ceiling, water leak, water issue.
Yeah.
Not properly fit tile.
That is correct. I was hoping somebody would catch that.
Yep, somebody got that. Loose tile, gap in ceiling tile is a fire hazard.
Excellent, Molly. Very good, very good. And so you don't know what that is on that ceiling tile, do you? You don't know what pipe that's coming from. I worked in an old building in Oakland where my office was in the basement and the restroom from radiology was right above my desk. And on occasion, there would be a leak. And I'm telling you, grossed me out. So I have no tolerance for dirty ceiling tiles at all. So they can grow fungus. There's moisture up there that needs to be repaired like immediately. Yes, Joe is correct about that too. So Joe, your fire code standards. So yeah.
So I
Correct.
want to just point out, because we didn't say this at the beginning of these photos, but these photos, Jean actually did take these photos in an actual center. So, we all love to think that we're on top of everything and the surveyor walks in, we would be good. This was just happened to be one day of the week and we made an appointment and Jean went in and just said, hey, mind if I look around and take some photos? And they said, yeah, sure. And she was able to find these just as an unannounced visit.
And many, many, many more. These are just the tip of the iceberg. And I will be adding some more of those into the non-clinical presentation because there are a lot of things that you find in dietary departments, in other parts of the building that really are definitely environmental tags that you could get. Okay, let's go to the next slide. Well, good job. Make sure you conduct regular rounds, as I said, using your interdisciplinary team, and do it at least once a month, especially if you're in your window of opportunity for survey. But the goal of survey preparedness is to always be in a state of readiness, because that will ensure that your residents and staff are kept safe. If major repairs are needed, they might need to be budgeted in the capital budget as a capital budget item. Make sure you do something to remedy in the short term and clearly document in your minutes in your infection prevention meetings that you have identified these issues and the money is going to be located to do the repairs. I did a mock survey in a nursing facility where the wallpaper was falling off the wall and they had mold behind it. So those types of things are going to score. So even though it's expensive to repair those issues, it's a priority. You must do that. And better to do it before you get tagged by a surveyor. Okay, next slide. Now we're going to go into greater detail in the antibiotic stewardship program. I know that this tends to be confusing to people. This slide, I'm not going to read through the whole slide, but what I will say is the antibiotic stewardship program is part of your infection prevention and control program. The goal is to reduce the use of unnecessary antibiotics, track prescribing patterns by provider, and ultimately to reduce the risk of multi-drug resistant organisms. And many of you may not realize that when penicillin first came out in the 1940s, you did not have to have a prescription to get it. So it was used by everybody for any reason. And now people, I think, have gotten to the point where they just think, if I don't feel well or if I'm sick, I need an antibiotic. And so it takes a lot of time and energy on the part of the provider to educate people that we cannot just give antibiotics anytime to anyone, because first of all, if you have a viral infection, it's not going to work. And secondly, this is how we end up with multi-drug resistant organisms. Next slide. So the goal is to avoid measure antibiotic prescribing by provider, and antibiotics are to be prescribed only as necessary for bacterial infections, and the correct antibiotic must be ordered. Let me give you an example. I work about 1 weekend a month on call for hospice, and I received a call from a nurse who said, I'm pretty sure this patient has a UTI. Well, hospice, we never actually do a culture and sensitivity, but she told me, urinary frequency, burning, foul smell, etc. And I said, okay, so you're asking for an antibiotic. And she said, yes. And I thought, well, hospice patient. All right. So she said, yeah, I want Cipro. I think she should have Cipro. And I said, well, you do know that the antibiogram for this county shows that Cipro, more often than not, is resistant. The organisms from a UTI are resistant to Cipro, and it's not going to work. She didn't know that. So you need to know, and of course she was asking for Cipro. She wasn't a prescriber, but I said, no, I'm not going to give that. I'm going to order something else that I know in this county is not the organisms that usually happen in this county are not resistant to. So that's why an antibiogram is very, very important. And you need to know, are providers just being called and asked by the nurse, can I have an antibiotic to give this patient who I think has a urinary tract infection? Well, how do you know they have a urinary tract infection? More often than not, if they've been in long-term care for any period of time, they may have be colonized. But colonized urine, that it's colonized with bacteria, is not a urinary tract infection. You have to meet the standards and have over 100,000 count in order to be a UTI. Now, if somebody is shipped off to the emergency department, for example, to have some stitches put in their head because they fell or they hit their head, they cut themselves somehow, and they do a urine dip and see that it's leukocyte positive, and they say this resident or this patient has a UTI, and they code for that so that they can bill for that and get additional income. But that doesn't mean that person has a UTI. And so they send them back to you saying, hey, they have a UTI. And then you do a urine and send it for culture and sensitivity and find out, no, they're colonized, that it's not a UTI. So be careful about that. Don't just arbitrarily give people antibiotics for what you think may be a UTI or a pneumonia, or when it could be a viral infection. So you have to be very, very careful. And that's where assessments, pulmonary assessments, and really assessing your residents is important. And we're not going to talk about that today, but that's another topic that Donna is working on that you may see in the future. And then if you see that there's a provider who's the culprit, who's prescribing the Cipro for UTIs or prescribing it for everybody, that's an opportunity to meet with that individual or have your medical director meet with that individual and talk about that. Because sometimes all you have to do is point it out, and maybe they weren't aware that that was their practice pattern. Okay, let's go to the next slide. Okay, so going on with the overuse problem, and we have developed antibiotic resistance, and we all know that. Each year, more than 35,000 people die because of an antibiotic resistant infection, which we have caused. We caused that by providers doing indiscriminate prescribing of antibiotics. Maybe somebody had a sinus infection and needed the antibiotic, but what happens if they only take it for 3 or 4 days instead of the prescribed 10 days? You're giving the organism the opportunity to mutate and to become resistant. More than 2.8 million infections occurring in the United States, according to the CDC's antibiotic resistance threats report. Treating 6 alarming antibiotic resistance threats identified by the CDC contribute to more than $4.6 billion in healthcare costs annually. Go to the next slide, and I think we'll see those. And here they are. These are the culprits. These are resistant organisms that weren't around when I started as a nurse. They did not exist. And the more we came out with bigger drugs like vancomycin, they would start prescribing drugs like that very indiscriminately. And now we have organisms that are resistant. So you can see it's just a huge problem. And so that's why CMS requires that antibiotic stewardship program be put into your infection prevention committee, into your program. Next slide. Okay, so antibiogram. I used to ask people, well, what does your antibiogram say? And often I'd get the look, the deer in the headlight look like, what are you talking about? What's an antibiogram? Well, it's a great tool for antibiotic stewardship programs. And it's a summary profile of antimicrobial susceptibilities of local bacterial isolates, testing results submitted to the clinical microbiology laboratory used by your facility. So your lab, where you send all your specimens, like your urines, when you think there may be a UTI, or sputums, or whatever you send to them, wound cultures, they are the ones who can give you the information on which organisms are resistant to which antibiotics. Antibiograms are used to assess local susceptibility rates to assist in the selection of antibiotic therapy. That's how I know in my county, Cipro is not a drug for UTIs, because that antibiogram has been done and is available. Antibiotic resistance is trended over time within a facility, at least for 1 year of time, and antibiogram susceptibility rates can be compared across institutions and used to track resistance trends. So say you send your microbiology samples to one lab consistently. You have a contract with one lab. That lab should be able to give you that antibiogram data. And then you can report that back to your committee. You can also use your pharmacist, and we know you either have one on staff or you have a contract with a pharmacist. That pharmacist should be able to assist you in tracking prescribing practices. Who's prescribing the antibiotics? What are they prescribing? And what are they prescribing them for? And that is an individual who really can be a huge asset to your infection prevention program, to the point where I highly recommend that you try to get your pharmacist on your committee, because that's a critical piece. Okay, let's go to the next slide. Okay, antibiogram data reporting. There are many examples of antibiograms that are available online, along with videos on how to report antibiotic usage and link antibiotic use to specific providers. If you have a software program, maybe even your electronic health record, that would be very helpful if you can mine that data from that software. And it is ideal, that's the ideal, to have that software program that can track the antibiotic prescribing patterns and drug resistance. Also, a lot of the data that you put into NHSN, you can also pull out and report to your infection prevention committee, and then up to your quality committee. So use that tool as well. Since you're mandated to enter data, you might as well be able to get the data back out. Okay, next slide. And I think this is a handy resource to know about. This is the Antibiotic Stewardship Toolkit. So AHRQ makes this guide available, and that tool will guide you through how to do an antibiotic stewardship program. So you don't have to create this on your own. All of these resources are available free of charge online, and we put that link, and Donna put that link in chat. So make sure you go and use that. Look at that and put it to use. If you don't think that you have a solid antibiotic stewardship program, then this will help you get where you need to be. Okay, let's go to the next slide. Okay, let's speak for just a couple minutes about F882, infection preventionist qualifications and role. Now, we know that this came about in November of 2019, where they said that you had to have at least a part-time individual who's identified as the infection preventionist, requires one or more designated people to fill the role, must work at least part-time in the facility and cannot work in a corporate role. So in other words, if you have an infection preventionist at a corporate level, they can evaluate your program and have some level of oversight, but they cannot be identified as the infection preventionist. You have to have someone on staff in your facility. And sometimes it's the staff developer who has to do 2 jobs. Other times it's the assistant director of nursing, or DON. I don't know how you could do both those jobs, but I have seen a variety of everything. My hope would be that over time, um, the resources would become available and reimbursement would become available to allow for this to be a full-time position. But I don't think we're quite there yet. Too many, as we know, too many issues of staffing and not enough staff. And maybe the infection preventionist is working infection prevention, but somebody calls in sick, so then they end up on the med cart. You know the drill. You know how it happens. These are some of the issues that I think need to be dealt with on a national basis. So often the person is just identified, hey, Sue, you're going to be the infection preventionist. And again, deer in the headlights, it's like, what does that mean? What am I supposed to do? I don't know anything about this. So the standard says you have to be qualified by education, training, experience, or certification. However, board certification is not mandated. It is not required. You must have completed some specialized training in infection prevention and control, and you have to participate in the quality assurance, assessment and assurance committee and report to the committee on the IPIC data on a regular schedule. And it's ideal to have your own infection prevention committee with your own champions on that committee. Okay, so and then it has to be, must be part of the antibiotic stewardship committee or subcommittee. So the individual has to be the one who is involved in everything infection prevention related. And if there's going to be a construction project of any type where you go into a ceiling or anywhere, the infection preventionist needs to be involved and do a risk assessment. So let's go to the next slide because we have a couple minutes left. And here are some education opportunities that I want to point out to you. Long-term care designated for nursing homes, but covers all the basics. This first one, these are free programs through CDC. CDC has this 23 module. It's the infection prevention training for long-term care facilities. 23 modules. You can do them in any order. When you complete the 23 modules and successfully pass the exam, then you get a certificate of completion in long-term care. This is a really good start, a good foundation base. And then STRIVE is a new one, States Targeting Reduction in Infections via Engagement. And this was a program that was put together by national infection prevention experts, led by the Health Research and Education Trust for the CDC. Courses address both the technical and foundational elements of healthcare-associated infections, HAI, prevention. And individual modules can be used for new employee training, annual infection prevention training, or periodically for training. So two really good, and I said free resources that you can use to assist in educating your staff, your infection preventionists. Next slide. And then, of course, we have professional associations that are invaluable. The Association of Professionals in Infection Prevention and Epidemiology, APEC, membership is $215 annually. And there's tons of education that you can take online, some free, some for a fee. But the beauty of this particular organization, you also get their journal, but the beauty of the organization is you can ask questions of experienced infection preventionists and get incredible guidance from people from all over the United States. There are also international members, but very helpful resource, especially if you're just beginning to put a program together or you want to strengthen your program because you know that there are flaws in it. And then they also are the ones who they provide an infection prevention certification, 2 levels. One is the associate, which is entry level, and the other one is the CIC. They don't actually give the test. They have another company that gives the test. But you want to make sure you have enough education and experience under your belt before you start reviewing for those exams. And then there's also the National Association of Directors of Nursing Administration and Long-Term Care, NADANA. Their membership is $130 annual, and it's open to virtually anybody who wants to join. You can see the list there: consultants, nurse educators, MDS nurses, staff developers, transitional care nurses and infection prevention nurses. They also offer online education, and they have a certification in infection prevention that there is a fee attached to that. So just so you know, those resources are available. Now I have, I think, gone over 1 minute. So I'm go to the next slide. And this is a fun poster. This is called Frog. And our colleagues at Alliant Health, who are another quality improvement organization, QIN, QIO, in some of the southern states, they put this together and they call it Frog. And friction rubs out germs. And it's a great picture of how to do hand hygiene. And the fun part of it is you put these up all over your facility, and if you're walking down the hall and you see somebody has forgotten to do hand hygiene, all you do is say ribbit. And when you say ribbit, they know. And it's like almost nonverbal ribbit, and they know to use hand hygiene. Okay, so let's go to the next slide. And again, the post-test polling questions and much more information will be found in the facilitator's guide. If you want to give continuing ed or whatever. And then there are 2 slides here of resources of things I mentioned. So let's go to the next slide and last slide. Okay, so that concludes this presentation. I'm sorry we went 2 minutes over, but I'll hand it back to Donna now.
Thank you, Jean. And that was a wonderful overview of infection prevention risks related to long-term care in clinical settings. Just as a reminder to everyone, it was recorded. It will be posted eventually. Our goal is that after our second presentation, which is on July 14th, focused on the non-clinical settings, that we will make available to you the recordings of both presentations, the slides for you to use on your own if you choose, and a facilitator's guide that includes the pre and post test questions so that you can take this and use it in your buildings to build up competencies related to infection prevention and control related to risks for the survey. We thank you.